So as we are continuing to go through our anatomical considerations within this project, as we're aiming to center this around movement or make the central point of meaning relate to movement, or the central point of the semantic network or the network of meaning, again, centering around movement, we're going to speak here about the movements or the muscles of facial expression, the structures involved with facial expression. This is going to be quite broad in its aim or in its nature on account of the fact that there are so many muscles for facial expression as well as mastication. And there are so many permutations in which they will work to make different facial expressions. So what we'll do is we'll note that movement exists, movement occurs, but we won't be very specific about all of the movements. We'll be very general. So although the majority of what we're doing is looking at particular movements throughout the body, in this particular case, we'll look fairly generally and acknowledge that movement occurs while not necessarily speaking about particular movements with each and every muscle or each and every structure. We'll just note facial expression and muscles of mastication, or mimetic muscles and muscles of mastication. So our general aims or our main objectives, again, a very superficial description of the muscles, mimetic muscles or muscles of facial expression versus muscles of mastication. Mimetic muscles are those that essentially make facial expression, whereas muscles of mastication specifically are for chewing. So they control the mandible in relation to the still cranium. So the muscles of the mimetic muscles control the skin in relation to the still cranium, generally, very broadly, while the muscles of mastication control the mandible with respect to the still cranium or the non-moving cranium. Very superficial description of nerves in the form of the facial nerve for the mimetic muscles and the mandibular nerve for the muscles of mastication. General description of the vascular and lymphatic pathways, general description of common etiology for these issues, and then description of areas of consideration for assessment and treatment. Now, we'll probably touch on that as we go. However, we will consolidate that at the end and make sure that there's at least some understanding of where to look, where to identify where problems may be co-occurring if there are issues with muscles of facial expression, and where to look to assess and to treat. So we'll consolidate that at the end. So the muscles of facial expression, as you can see, there's quite a few. Very, very broadly speaking, the things that are the same about these muscles are that they have a connection, a bony connection to the cranium, so to the skull, in some way or another, and then their other connection or their other attachment point is to the subcutaneous connective tissue. So they go from bone to skin. So the primary aim of the muscles of mastication is to move skin in order to make facial expressions. Those facial expressions are communicative, right? So they aim at communication primarily, and although it is not absolutely required, the muscles of mastication aim in communication, at least verbal communication. Verbal communication can occur without the mandible moving, but it's obviously muffled, such that the muscle of mastication do aid in communication, especially verbal communication. However, for the most part, we can say that nonverbal communication, at least with the face, is done by the muscles of facial expression, again, because its aim or their function is to move the skin in relation to the relatively still cranium. Another thing that can be said is because there are orifices in the head or in the cranium, that some of the muscles, so particularly orbicularis oculi and orbicularis oris, are sphincters because they go around the orifice and they can close the orifice, or they can close the orifice. So very broadly speaking, orbicularis oculi and oris are also considered sphincters. So again, very generally, lots of muscles. They are organized in different ways when being described. So personally, I've seen at least two different descriptions. One of the easiest ways to describe them is in relation to their branches of the facial nerve. However, I believe I have seen another form of organization. So there's different forms of organization, but generally speaking, you can track them based on their innervation from the branches of the facial nerve, which we'll touch on briefly in a moment. When you're considering the muscles of facial expression, as far as arterial supply, you're considering the external carotid artery, and then the specific branches being the facial artery and the superficial temporal. So you've got the external carotid coming in and around the angle of the jaw, shooting an artery forwards under the angle of the jaw, and then up to supply stuff, basically orbit down and forwards, and then the superficial temporal will give branches that will get the rest of it, right? So basically the front of the head is coming off, or the front of the face is coming off of the external carotid one way or another, facial or superficial temporal. As far as venous drainage is concerned, you again have the facial vein coming down, taking stuff superficially down to the angle of the jaw, going to the external jugular vein. There are some portions of facial drainage and the drainage to the facial musculature, at least through the veins, that will go into the pterygoid plexus and then internally. So some of that will go to, some of it at least will go to the internal jugular vein. Either way, with respect to the internal jugular vein, you're considering the angle of the jaw, you're considering, or so you're considering the mandible itself, or the TMJ if you'd like to put your attention there. You're considering the SCM as well. So regardless of if you're considering the external carotid artery, or you're considering the internal or external jugular vein, you're thinking about the mandible and you're thinking about the SCM. You may be thinking about, to some degree, the suprahyoid musculature there. As far as structures where if movement is altered or muscle tone is altered, you can alter pressure, thus altering, at least on some level, if they relate well to one another, vascular flow. But those are the areas that you're thinking about. So again, we have facial vein, some will go to the pterygoid plexus, so we'll go internal, and then you have the superficial temporal vein as well, both going to the external jugular, and then you'd have some in the internal jugular. But the structures that you consider superficially, as far as assessing and treating, would be the same for both external carotid and the internal and external jugular. It's the same areas. As far as the innervation to the muscles of facial expression, you're considering the facial nerve itself and its branches. Now, the facial nerve, if I counted right, is 6 branches. I'm off the top of my head, I'm going to mess that up a little bit, and as I'm rolling through this, I mess it up a little bit. But essentially, what you have is branches. They're going to come out in and around the ear, right? So when you're considering the path of the facial nerve, you're considering the ear. So it's possible that things like soft tissue manipulation of the ear can alter it, or can do something. If there is something going on with the facial nerve, it's very unlikely, but at least possible. Areas where you're going to be more curious would be the TMJ or the mandible and how it's moving. Now, what happens with the facial nerve is you have a branch that goes back and then branches that go forward. So the branch that goes back is the posterior auricular. So that's going to go to the posterior auricular muscle, which really in most people is not going to create much movement. It's possible, but most people can't move their ears. The muscle's there, it's not going to do much. And then it goes to occipitalis, right? So I believe it might hit some other muscles. But basically you have the thumb going back, and then you have some branches that do this. Now, don't have enough fingers to do it, but there's a mnemonic to talk about the branches of at least the facial branches of the facial nerve, not necessarily the posterior auricular, but it's to Zanzibar by motor car. Now, for some people, that's going to work well. For other people, it's not. It's what you're doing there is you're creating a semantic network. So you have a phrase that then relates to the piece of information. So I'm attempting to help you build a semantic network that focuses on movement, but if a mnemonic is another way to help build that semantic network, then that's fantastic. The T or the 2 is temporal branches of the facial nerve. The Z, or for Zanzibar, is the zygomatic branches. The B is buccal branches. The M is marginal mandibular branches, or mandibular branches, depending on who you talk to. And then the cervical branches is really only the platysmas. The platysma is very, very superficial. It's going to kind of tighten the neck. All right, so stuff like that. Or tighten the skin around the neck at least. So those are your branches. Now, we're not necessarily going to spend a ton of time talking about what each one of them innervates, but that's what you've got going there. Now, the reason the picture that I'm covering, and I'll wiggle my window around here, the reason we have this picture here on the right of the screen is because that one clearly shows the posterior auricular branch going backwards. Now, the other thing to note specifically about the facial nerve is that it goes directly through the parotid gland, right? So it's going to innervate the parotid gland to some degree. It's also then going to send off the branches, the temporal, the zygomatic, the buccal, the mandibular, and the cervical branches. from inside of the parotid gland. So if you're considering the parotid gland, so first of all, you're considering the path of the facial nerve coming out in and around the ear, right? I forget the specific framing off the top of my head, but it's in and around the ear. So soft tissue pulls, the mandible itself. Now, the mandible itself is also going to relate highly to the parotid gland, and that's one of the reasons why you'll see, at least with facial nerve issues, that the mandible can be a structure that can have some impact here. The parotid gland, obviously, if there's some form of growth with respect to the parotid gland or pressure with respect to the parotid gland, then you can have issues with the facial nerve. So these are highly related things because they touch each other and pass through one another. As far as the muscles of mastication are concerned, these are going to be the temporalis, the masseter. So the temporalis and masseter from cranium to mandible, kind of on the outside, or superficial to the mandible to some degree. Then you have the pterygoids, the medial and lateral pterygoids. And those are going to come from the pterygoid plate of the sphenoid. So those are a little bit more inside. So it's kind of like they're inside the mandible and go towards the mandible. So the sphenoid, or the portion of the sphenoid, being inside and then going to the inside of the mandible. So you're going to have different pulls. And we're not necessarily going to discuss each one of the functions here, but we're going to note that there's some outside and some inside that will attach to the mandible and move the mandible. As far as access points to these muscles, there are some arguments where you would work inside the mouth. However, in most jurisdictions, osteopathic manual practitioners are likely not able to work inside the mouth just because of regulations. And even if you are, then you still may not find it all that intelligent to work inside of the mouth or intraorally. If you're going to look at old descriptions from old osteopathic practitioners, one being Dr. Still talks about going inside the mouth, but over top of the teeth to get to some of the muscles of mastication. However, what I would say is if you just pinch the cheek, now obviously this is going to be more masseter and temporalis in here, but you can hook around it a little bit and get in there. So you can be over top of the skin and you can get at least to some degree to the soft tissues. However, what I would say is that if you're going to consider the TMJ or the muscles of mastication, often you don't necessarily need to work on them directly. You can just work on the joint. So these are considerations. As I said, we'll talk about this in some way, shape, or form as we go through and consolidate this at the end. But basically, a good old cheek pinch can give you access to some of these muscles. Now, as far as the artery is concerned, you're again considering the external carotid artery and then sending off the maxillary branches. Or is it the maxillary? Or yeah, it's the maxillary, the maxillary artery, or the internal maxillary artery, then sending off branches to these particular muscles. But then again, that is again sneaking behind the mandible or deep, so or medial to the mandible to supply these structures. Now, in doing this, again, the areas of high yield for this particular artery would be the SCM and the mandible itself. So you're seeing consistent themes here as far as the places that you would go to treat if you're or assess and treat if you're concerned about the muscles of facial expression and muscles of mastication. SCM and mandible are quite high yield for these structures. As far as the drainage is concerned, the drainage is going to be, again, quite similar to the muscles of facial expression. So in this case, you're probably going to be getting it off of the maxillary vein, or it may be named slightly different, but you're going to get blood going to the external jugular vein there. So again, same areas, although this is obviously a picture of the arterial side. As far as the nerve supply, or the motor nerve supply to the muscles of mastication, you're looking at V3 or cranial nerve 5 branch 3, which is the mandibular nerve or mandibular branch. Now, that's going to give you tone. So it's internal or medial to the mandible, and then it's going to travel to the muscle. So it'll travel to the pterygoids and then travel to temporalis and masseter, but it comes from inside. So it's essentially medial to the mandible itself, again, giving you some signal that the mandible, again, is high yield if there are issues with the mandibular nerve or the muscles that are innervated by the mandibular nerve. As far as lymphatic drainage for the muscles of mastication and the muscles of facial expression, or the mimetic muscles. This is going to be a very similar set of pathways. You're looking at the general lymphatic drainage to the face. So some of that is, or the head really, some of it will go internal and then essentially get to the cervical lymph nodes. So it's going to follow basically the line of the bones, more or less, and the SCM. So as far as issues, if you saw swelling in the face, you would want to heavily consider general cervical treatment specifically of the SCM, treatment of the mandible or movement of the mandible, the suprahyoid musculature, the infrahyoid musculature. So there would be a lot of checking of soft tissues and its compliance or movement, the mandible, and generally a cervical treatment. And then you would also, if that wasn't necessarily doing the trick, you consider the clavicles and the upper ribs at least, if not the rib cage. But again, the consistent highlights: mandible, SCM, and in this case, we add in the hyoid musculature, so supra and infrahyoid musculature, but that is where you're going to see the lymphatic drainage or have some mechanical relationship to impacting the mechanical or the lymphatic drainage. So you're basically following the lines of the bones. You're looking at the SCM, and then again, posteriorly, it's still aiming for the same place. It's still trying to get into the thoracic duct and the right lymphatic duct. That's essentially where this is all trying to go. Now, as far as issues with these, both of them, Bell's palsy is a facial nerve paralysis that can be caused in multiple ways, but essentially you're going to consider things along that line, but you're more so going to consider it centrally, right? So it's going to more so be close to the ear if there's going to be something, or it would be internal to the head. So there are multiple ways that Bell's palsy can be caused, but Bell's palsy would essentially look like paralysis of one side of the face. Now, with respect to Bell's palsy, there does seem to be reasonable resolution of many of the symptoms with appropriate medical treatment. I don't necessarily know the efficacy specifically of osteopathic treatment or if particular research has been done. So I would say that maybe you can have a positive impact, and even if you can't, you can still treat those areas, and whatever impact you can have, you will have. But I don't necessarily know that hands-on treatment particularly is going to do anything to Bell's palsy or facial nerve paralysis. But what you would be considering there, because of the course, you would be considering the mandible more or less in its entirety. And that's probably where you're going to be able to do something for Bell's palsy, because Bell's palsy is full facial nerve paralysis, whereas blepharospasm is orbicularis oculi specifically twitching. So essentially you're looking at, and the muscles of the midface, the spasm may also go there. So you're getting some blinking. Now, the thing about orbicularis oculi is it gets branches from the temporal branch and the zygomatic branch. So basically you'll see stuff through here twitching, which means that it is not necessarily going to be central. It's not going to be the whole facial nerve. It's going to be something between here and here, which is going to be tougher. So that can be caused by neoplasm. Now, neoplasm is an abnormal growth of cells, which could be benign or malignant, so it could be cancer. It may not be cancer, and you may not call it a tumor. You're usually going to call it a neoplasm, so it's a growth of cells. And that can put pressure, so you can have a growth of cells basically somewhere between here and here that would put pressure on the artery and the nerve that would lead to that twitching. The twitching tends to be somewhat irregular. But if you see somebody twitching, so eye twitching in an irregular fashion, or twitching in the midface in an irregular fashion, it's possible that there is some form of pressure on the artery or the vein, or the artery or the nerve rather, but it's going to be somewhere in here, right? Somewhere just in that area. And that may not necessarily be amenable to osteopathic treatment or hands-on treatment generally, but if it was going to be, you would be considering something in the soft tissue, and you would be considering the jaw, the mandible, and you would be considering the SCM as far as vascular supply is concerned. The nerve is going to be taken care of mostly by the mandible, and the vascular supply is mostly going to be taken care of if there is a relationship between blepharospasm and a nerve or an artery. That's where you're going to have an impact, if there's an impact to be had. Bruxism is teeth grinding. Now, teeth grinding usually is occurring at night. Now, if it's occurring at night, it is commonly caused by central neurotransmitter issues. Now, the patient may not necessarily be aware of this themselves because they're sleeping. So the person who is going to be able, or the people who are often going to identify bruxism at night are going to be somebody who has shared sleeping arrangements, or a dentist. A dentist will often note uneven wear of teeth. So bruxism at night is not necessarily something an osteopathic practitioner is going to identify, but they may be able to, through interview, if it is identified by somebody else and you are of the belief that you may be able to find something, you would again look through at the mandible itself to see if the mandible is moving okay because of the path of V3 or the mandibular nerve. And then you're going to consider the SCM and the neck generally again, on account of the fact that if you're considering vasculature to be having some impact, that's where you're going to have an impact in assessing and treating. There is bruxism during the day, and that's usually caused by stress or other behavioral considerations. Now, as far as treating the mandible, that's not likely to have an impact on daytime bruxism or daytime teeth grinding. It doesn't mean osteopathic treatment wouldn't have an impact. It just means that if it's going to have an impact, it's probably going to be somewhere else. So if the patient is very stressed out, the impact that osteopathic treatment is going to have may be somewhere else in the body or many other places in the body. So if it's daytime bruxism or daytime grinding, it's not likely that treatment in the cranial region or in the facial region or in the neck is going to have the same impact as it would if it was bruxism at night. Now, bruxism at night being more about central neurotransmitter issues, there's an argument to be had as to what degree osteopathic manual treatment would have an impact on that through vascular pathways or through treating the soft tissue or the neck in relation to the vascular pathways. It may be low impact. It doesn't mean it won't do anything. It just means the impact is more likely or more predictable to be low. That doesn't mean you won't have a positive impact if you treat the mandible and the neck of the patient. It just means it may not have the impact of dealing with bruxism. Now, all of these are fairly safe to treat. You're not necessarily going to make any of them worse, but you may also not make any of them better. It doesn't mean you won't have a positive impact on the patient. You may just not make these things better. So Bell's palsy presenting itself, bruxism presenting itself, or blepharospasm presenting itself, you may not have much of an impact on those things, on those identifiable issues with the facial nerve and related muscles, or the mandibular nerve and related muscles, but you may have a positive impact on the patient. Right? So you may actually be able to identify issues with movement in these regions that may not necessarily relate well to the conditions that are presenting. Now, as far as what you might expect to see if there was something else going on with either the facial nerve or the mandibular nerve, you may expect to see some deviation of the jaw, right? So if there was a paralysis of the mandibular nerve on one side, you may see some deviation. You may see people, this is not necessarily going to be indicative particularly of an issue with the mandibular nerve, but as people open and close their jaw, if you ask them to just open and close it, it may open and then shoot over to one side. That may just be the shape of the jaw or the tension in the muscles. It is difficult to pick between them. But what you would see if there was an issue with one side of the mandibular nerve, you'd see deviation that wouldn't necessarily correct itself, right? Or it would be difficult to correct itself. So then you may have some impact by treating the jaw. If it is a true palsy, maybe less so, but you will see deviation of the jaw, which is usually amenable to treatment, but it may not necessarily be an issue with the mandibular nerve. It may be the shape of the TMJ or one of the surfaces of the TMJ, or it may be just uneven tension through behavior, which you might be able to help. So that's probably more amenable to treatment. As far as the palsies of the facial nerve, treating, if it's going to do something, treating the jaw again will have a positive impact. Treating the SM particularly, again, the neck generally may have a positive impact. But another thing with, particularly with the parotid gland, is you may also, so you may have a Bell's palsy and then an issue with the parotid gland, or you may have some twitching and an issue with the parotid gland because of the innervation and the passage of the facial nerve through the parotid gland. So these are things that you may see that come together. As far as you being the first person to note them or the first practitioner to be presented with them, what I would say is refer out to another healthcare practitioner so that they may provide a fuller diagnostic, because as osteopathic practitioners, all of our tests are centered around motion. We test motion, we treat motion, we understand the underlying anatomy and how these things relate, but we treat motion. We don't necessarily treat a neural palsy or a nerve palsy. There are other ways that are quite successful that are very much worth sending your patient towards. So if you notice these signs, so deviation of the jaw that won't correct itself, bruxism for whatever reason in the interview process, if you note it, send that out. Send all of these out, but they are safe to treat. So these are not necessarily big glaring red flags. As far as treatment is concerned, you may have a positive impact on the patient and not the condition, or you may have some degree of impact on the condition, but aim to have your treatment impact the motion for sure, and possibly the condition if these are things that show up.